This is Market Pathways, your premium guide to global medical device regulation, reimbursement, and policy. Become a part of the global medtech community at mystrategist.com.
Welcome to another edition of the Market Pathways podcast. I'm Steve Levin, Editor-in-Chief of Market Pathways and MedTech Strategist. And today we've got an interesting conversation with Tamara Syrek Jensen. Tamara is a name familiar to many in the medical device industry. She spent about 25 years at CMS, including the last 10 years running the coverage and analysis group. This is a conversation taken from our San Diego Innovation Summit. And the interesting thing about this interview is that you rarely get the opportunity to get government officials generally, never mind CMS officials, to speak openly about the reimbursement system specifically, and also as it applies with Medicare. And in this instance, Tamara was unusually frank and candid, talking about the issues facing CMS, talking about issues between CMS and FDA working together, such as the parallel review process, something of which she is not a big fan, as well as recommendations for product companies as to how they could best get over some of the obstacles in dealing with both FDA and CMS, but specifically some tips in terms of smoothing out the process of working with CMS, which, as everyone knows, has historically been a difficult agency for companies to work with. We hope you enjoy this conversation with Tamara Syrek Jensen. There's more to talk about reimbursement, and again, the focus of this discussion really is intended to be more broad-ranging and go beyond TSET. And one thing that I didn't get to ask you on the morning session is how you got to CMS. We talked about how Steve Farmer and how Laura got there, and I think how Perry got there. For people who don't know, Tamara is a lawyer by training. We don't hold
I don't admit that.
We don't hold that against you. I'm a recovering attorney as well. So, but how did you get to CMS? How did you develop an interest in health policy generally, reimbursement specifically?
So, all very good questions, which I do not have a very good answer to. You know, you listen to Dr. Farmer and Steve Farmer, and he had it. You know, you can tell why he should be the chief strategy officer, because he had this whole plan from the moment he was, I don't know if he's there, but like 5.
Right.
And so my career path was definitely more organic. And if you ever met me in an undergrad, I guarantee you would have had a really good time. And then I grew up. And I got serious about life, and I really put my head down. And my first job out of college was on the Hill. So I started in Capitol Hill as a policy person.
In healthcare or just policy general?
Just policy generally, but my boss was on the committee for Ways and Means. He was on Ways and Means, and hopefully many of you know who that is. But that is for CMS. That is one of the committees that writes laws for CMS along with the House Commerce Committee. So that was one thing that I was really, really interested in. And then I decided, well, I'm bored with this, so why don't I go to law school? And I said, well, I can't just go to law school. I really did put my head down. I want to work full time as well, because why not? And so I worked at CMS and went to law school at night. And that's kind of how I got into it. And then I stumbled into consistently getting promoted within the agency. So I started off as an analyst for the conditions of participation. If anybody knows what those are your minimum standards if you're a facility to be able to treat Medicare patients. I then got into being a special assistant for the center that I work in right now for the chief medical officer. So I got a really good point of view of the whole agency. And then I landed in the coverage and analysis group where I am now. So I say that I do that organically. I feel like I was talking to someone about this last night. I had a lot of people that I may not have officially said were mentors, but they certainly held my hand, and they certainly helped guide me through the journey. that got me to where I am today. And I am very grateful to those people. And I try to repay that today to anyone that I work with or see or, any which way.
But it's always interesting, I find, when I'm interviewing people either for an article or in a forum like this, because people come to MedTech, broadly speaking, from such a variety of interest, skill sets. That's one of the reasons I was asking Steve and Laura as physicians what drew them. So you worked in policy, but then you honed in, I can't believe it was just the only job you had was that you could get was at CMS. You chose that for some reason.
I did.
So what was there about payment, reimbursement, the role of CMS that was somewhat attractive to you, even at an early stage, probably before you knew a lot of what CMS even did?
It's true. So I was just talking to someone half an hour ago. So when I started on the Hill, I made $19,000 a year. So it was a pay raise to a little bit that I got when I went to the feds. Part of me, as I was looking at what are my career choices when I got out of my undergrad, and I thought, okay, maybe I want to go to med school, but then I was like, wow, that's a lot of prereqs I would have to do. And I said, well, law school might be a lot easier. And so I think I've always had interest in healthcare. I think I've always been a policy wonk. I've always, all of those things. Initially, I was really into politics, which brought me to the Hill and then exposed me to healthcare and all the complications with that. I'm not sure at 24 I understood complications, but you learn all of that. And there was never a plan. I never had a plan, and that there's good and bads to that. And so I bumped into a lot of different things. And when I only did apply to CMS, and I got offered a job to write regulations or in the Office of Legislation. And I'm really, really grateful that I picked the path of policy, or I wouldn't be here today. Mm-hmm. And it's been a really rewarding career. I have enjoyed being a public servant. I really enjoyed serving the American public and trying to do the best I could for healthcare, and there's a lot of mistakes that were made, but there's a lot of ways to fix them too.
Right. And I want to get into that because obviously when you were at CMS, and you were always generous with your time talking to myself and my colleagues in the press, but subject to the limitations of what you could say and how you could say it. But you always did that, even if it was a no comment, you always did that very politely, so I have to compliment you for that. But now that you've stepped away, and again, this is, this audience, this is in no way a bash CMS, bash FDA, or bash the government session, but you heard, I'm guessing, the conversation with Mark Leahy and Josh McNamara.
I did.
On the last panel, kind of looking at policy from a longer-term perspective in terms of what we're currently facing in terms of the situation, and not just whether it's DOGE or the shutdown, but just the issues, generally speaking, around, and specifically healthcare reimbursement. What's your take now, being out of the government, as far as the scope of the problem, and more importantly, the ability to address the problem? Because Josh made a point that I was going to ask you about, which is, and we're going to get into CMS FDA comparisons, because in spite of the different missions of the respective agencies, it's just inevitable that there's going to be comparisons, whether by industry, patients, providers. But one point that often goes underappreciated is the fact that for as difficult as the regulatory world is, and it's no doubt if we were having this conference 15 years ago, circa 2010, and you polled the CEOs in the audience and asked them what the biggest challenge that was facing them, they would have said the FDA and regulatory. And of course, that was the time when CE mark was easier to get, more transparent. Everybody was going to Europe first. The FDA was very, very difficult. And again, kudos to Jeff Shuren and his team for turning that around with the help of some user fee money, but they did the job. And now I think if you talk to people, the consensus is that reimbursement is really the biggest issue. But often lost in the shuffle there is the fact that as difficult as regulatory is, you're dealing largely with one agency. And when you talk about reimbursement, you're not just talking CMS, you're talking private payers, you're talking the role of AMA, you're talking the role of clinical society. I mean, it's a multifaceted problem. And that's something that, again, I think sometimes is overlooked because people look and say, well, look how we improve things at FDA. Why can't we do the same thing at CMS? I'm not saying we can't, but address the complexity of dealing with the reimbursement climate generally.
Well, gosh, that's a really complicated question.
Pick any piece of that.
Yeah, and even you look at the whole ecosystem and you say, how do I fix it? And I just asked, I asked Josh after he got off the stage, I said, okay, you said you have a solution. How do you fix the ecosystem? And there's not one answer. It's really hard, and we all have to do that together. So reimbursement is so challenging because you heard it on the stage with Mark and Josh, as you just mentioned. I mean, oh my gosh, it's just like, how do you pick it all off? You've got coverage, you've got the three-legged stool of fee-for-service, right? Coverage, coding, and payment. There's so many complications just with those three things in fee-for-service. I didn't expect this, but I just 5 minutes ago was just talking to someone who innovated a device that right before I left, I was doing a deep dive on. Because I was trying to find, when I say I mean we at CMS, I apologize. I was trying to find to address some of the things that you just talked about, which is FDA has solved, I'm exaggerating, FDA has solved everything, they're not a problem. They're good. But you, CMS, you are the problem child. You're my teen that I have to yell at every single day, and we need to get you in order. And so I had heard that for a long time, and we were collectively, Steve and Laura, whether it's TSET or anything else, we were trying to figure out a way to address that within the realm of what we had. And so one of the things I was doing in this particular device was part of that was like, how can I write an NCD really, really fast? How can I do that? How can I make it really, really short? How do I do it really, really fast and just get it out there, close to FDA approval? So it was really interesting to talk to him in the audience because they didn't know, we were trying to do this behind the scenes. It was nothing to be public, it was just trying to test some of these things to address what you're saying and to address what many of you have said to us, which is FDA has gotten approval, you guys haven't done anything. And there's a lot that I can talk about there because there's a lot of nuances there. So that's, then even if you get coverage, you have to deal with, make sure you have a code. You can have coverage, and if you have no code and your payment is zero, so what? That's not going to help you. Maybe it will help you maybe it'll help you with MAs. So you have to have all of that. And then on top of that, because it's no longer a three-legged stool, it's a four-legged stool because you have MA plans on top of it. Right. So how do we fix that? NCDs and LCDs are part of that solution, maybe, because what they do is they create predictability. So not only do they create predictability of whether you're going to pay in the fee-for-service system, it creates some predictability, although you heard some challenges with that earlier, in whether an MA plan is going to pay. But even if there's some challenges with the MA plan, at least you have something you can stand on. And then I don't know how to answer that question because there's so many challenges with it. And I would love to hear from others, and I could address it of like some of the things we can do, whether it's TSET, which I think is part of the solution, CED is part of the solution. How do you streamline coverage, coding, and payment, which we are making progress on as well? And then how do you incentivize innovators to continue to innovate, but also be able to demonstrate why it's of value to patients to then have payers want to invest in it?
I want to get back to TSET, but you mentioned private payers. So let me kind of jump ahead and try to tackle that issue. Your current, I guess he's not your boss. I don't know, what is Lee Fleischer? Your
He's my
colleague.
boss.
He is
Yeah.
your boss.
Colleague,
anyway,
boss.
Lee and former Commissioner Califf
Yes, Rob.
published an article relatively recently talking about the need for increased collaboration with private payers and talking about what can the government, private payers, and industry do, raising the fact. And when you look at that, do you see a role for industry? And again, Mark Leahy mentioned this in the previous panel, to try to work together, because again, one thing that seems clear from what you're saying, from what the previous panels have said, I mean, nobody can fix this in a vacuum. And to a certain extent, that's why FDA is kind of the outlier. Not that FDA was in a vacuum, but they don't have the range of issues and influences affecting them the way the reimbursement process does. So do you see a way that industry can effectively try to work with, whether it's AMA? I mean, AMA has said, they've said some positive things over the last few years to try to open up what previously was really a black hole. I don't know, they haven't made much progress beyond that, but they've said some of the right things. But when you think about that issue, what role, is there a role for industry to play in that?
Absolutely. Anyone who's met me knows, I hope everyone knows, I wholeheartedly believe you need to have every opinion around the table, industry, government, clinicians, whatever it is, they have to be around the table. You have to be able to have a space that you have a conversation, you disagree, you agree, you figure out. You can't all agree, because if you all agree, I don't know that you're moving in the right direction. I mean, that never works out. You have to create that space where we can hear everybody and then try to collectively find that solution. And you will always learn something every single time. I may not agree with it, but I'll learn something, and it will always change slightly when I was a policymaker, where I was heading. The thing that I valued the most is when I had conversations outside of these meetings as a policymaker, because I would bring them back every time, because it made me think differently. And then we would experiment and try different things. And so I wholeheartedly think you have to have everybody around the table, whatever that means, to try to figure out what the solution is, because I think the solution is really hard. And I don't know what it is, but there has to be something that's different about it. And one of those examples that I live by is our Medicare Evidence Development Advisory Committee. I was adamant we always should have people on that committee that we may or may not, that we don't agree with, always having them on that committee to speak that voice, because it was necessary for a policymaker to have that.
One of the challenges that I know I hear from companies is that, and this again, maybe I referred to some of the myths of reimbursement, and this may be a myth of government interaction, is that just a sense that there's an anti-industry bias on the part, and again, you can't generalize about everybody at CMS or everybody at FDA, but there's a feeling among industry that they're coming in and people have kind of a chip on their shoulder, and there's an assumption that they're not going to be working towards the same goals. Did you run across that at all in CMS, or did you run across that perception on the part of companies?
Sure. I mean, to be honest, I probably had a little bit of a bias. And so we all have biases.
Sure.
And so there absolutely. And some of that was from experience, where I had, one of the things that I really live by personally and expect for people who come into the agency who would talk with me is honesty. Just be honest. I can work with it, just be honest. and it was really frustrating for me early on, and then we talked a lot more with FDA, was when we would have these conversations with manufacturers, and they would tell us one thing, whatever it was, and then we would talk to the FDA and like, no, that's not really what it was. And so that was really frustrating, and that was partly the reason that CMS and FDA, among many other reasons, that we would work together. I really believe, though, in the last 10 years or so, that is not, I don't know, I think there's been a paradigm shift. I think there's now a lot more, at least in my perspective, manufacturers are willing to have the conversation that really is needed to be had now with CMS. Like, we're not perfect. The evidence isn't perfect. But we really do see that there is a benefit here for patients. So the conversation is, how do we get there? And that's a good conversation, because as a policymaker, it's a lot easier for me to say yes, to try to get you there, because when we say no, I mean, that's really hard. That's a lot more of my time. And so it was being creative, and that's how you got CED, and that's how we got TSET, and so we can still be creative there. But yes, I think there is a bias, and I think some of it's unfair, but there is one.
Hey, have you heard of Market Pathways? Market Pathways provides the most in-depth analysis you'll find of the changes happening in medical device regulation and reimbursement every day. They address the complexity in regulatory affairs and beyond by helping you digest and contextualize technical topics like Medicare and MDR. Visit mystrategist.com/trial today to start your free 5-day trial to Market Pathways. Again, that's mystrategist.com/trial for 5 days of online access.
Well, let me also flip it around somewhat, and that is, I think there's a bias on the part of industry towards CMS.
Absolutely.
As well. And for example, I can't tell you the number of companies that tell me, well, CMS won't talk to me, I can't get anybody. And you know, if I might happen to mention, well, you can meet with CMS. I mean, it may not be as formal as the pre-sub process at FDA, but that may be an artifact of past years. Maybe there were times when that wasn't true. I don't know if you can speak to that as far as the history of CMS, but I mean, I certainly know now it seems that the agency is making an effort to, make themselves more available. But talk about that, because that, I think, one of the big criticisms of CMS historically has been the lack of transparency and the lack of openness/accountability.
So I think there's some truth to that. I have wholeheartedly believe in transparency where you can within the law. There are limits to what we can be transparent about, and we can go into those nuances. I also tried very hard, sometimes to the absolute dismay of the coverage and analysis group staff, because I truly believed we needed to have these conversations. And so the door was always open, and we would always have these conversations. Now, with it being said, sometimes the third, fourth, fifth time you come back, right. And so there's only so many times and there's only so many staff, but I was a true believer in having that door open, having that conversation, because I think there was to your point, there's distrust. And when you don't talk to people, there's distrust because you're gonna fill that void with a story. Sure. And so the only way that we could get rid of that distrust and figure out a plan forward is if we opened the door and had the conversation, so that the agency could hear you. We can disagree. I have disagreed with probably many of you in this room, but I do agree with many of you in this room as well. But at least you knew what that was, and that's important. And so we listened, and you heard us, and so it started the building blocks of that trust to be able to figure out a way forward. I don't know, and others should chime in here, yourself included, I think that was at least the environment in the coverage and analysis group. I don't know about the rest of the agency. I think it's starting to open up, but I think it was less so in the rest of the agency and a little harder to get into. And then I just heard about it, that it's really hard to get into the Medicare administrative contractors.
Right.
What I would say to you, just one piece of advice, if you can't get into the Medicare administrative contractors, their job is to talk to everybody. So talk to CMS, and they might be able to help you open that door.
You know, you mentioned statutory standards, and I want to get into FDA and CMS and obviously the different standards. Another point that I hear from companies is that the reasonable and necessary standard is not sufficiently well defined, especially if it involves any scientific or clinical assessment. Let me ask you if you share or at least understand that view or perspective, and what can be done to improve or maybe even correct, if it's a wrong view, industry's understanding of that standard without adding greater complexity to the process and kind of throwing the baby out with the bathwater.
So there's a lot of answers to this question, but I don't think that there's over 500 national coverage determinations. Just throw them in AI. My guess is you're going to find just about every disease type what the endpoints are that CMS is looking at. Over the last 5 years, maybe less, we have tried, we heard that. And so I think, I will be honest, I think some of it is a little disingenuous because there are over 500 national coverage determinations. And so there's a good idea of what we're looking at, which is, what is the benefit to the Medicare population? And looking at the Medicare population, because as I said earlier, it's not a population, it's a population that's unique.
Right.
And there are certainly very healthy people in the Medicare populations, but there are also very sick people in the Medicare population. And like I said, on average, there's between 3 and 6 to 12 different comorbidities, and so all those are important. But in the last few years or so, we put things in guidance documents, like how we're going to review evidence, to try to take some of those questions away, and to do all of to really try to hone in on that and to help everyone out, and then always having meetings. But I wanted to go back to the comment of reasonable and necessary is not defined. So, and I have heard that my entire career that I've been in coverage and in the coverage group. So the question that I would throw out to all of you and to you is, do you want them to define it? Because sometimes you want to be careful for what you ask for, because one can define it, whether that's in legislation or in regulation or however we want to define it. But the government's not fast moving. And what was happening in 1965, if we defined reasonable in 1965, I would guess probably 99% of your devices probably wouldn't fall under that definition. And I would be really, really worried about that. And so my personal philosophy, and this could just be how I grew up in the policy world, is I like things that are flexible so that it can grow as the industry grows. Now the trade-off with that is there's less certainty on what it might mean. Now I do say there's 500 NCDs, so you have a pretty good idea of how we're looking at it, or how CMS is looking at it. And so when I was the director, and it may change, I resisted writing a regulation on reasonable and necessary because of that. I didn't want our hands tied, because I think if CMS's hands are tied, that means your hands will be tied, because then it will be we're going to read that really literally. And that's going to be really, really hard. And there's only so many things you can be creative about with words. And I love being creative with words, but that's going to be really hard. And so I mean, you have to weigh, do you want the definition or do you want flexibility? And I don't know that I know the answer. I know at one point I threw up my hands and said, let's just define it. So, and we could just adopt the definition that's in Chapter 13 of the Program Integrity Manual.
Well, let me make a big leap. Do you have the same concern? And again, this morning we talked about, and Mark and Josh also talked about, the possible legislative fix to TSET as opposed to a regulatory/administrative approach. And a lot of people have concerns about Congress trying to.
Same concern.
Right, exactly.
Right? Absolutely. Be careful. I'm not saying it's a good or a bad thing. I mean, I have opinions on that legislation, but let's say the legislation is the best thing written perfectly. It's really hard to get it perfect. A good example of this is the appropriate use criteria for imaging. Congress wrote a statute that, because there was, at the time, there was a belief there's overutilization of imaging. So this was a compromise between the imaging community and Congress on how they were going to do that. And CMS are going to create appropriate use criteria. We're going to do real-time claims, all these things to make sure you could guarantee payment, et cetera, et cetera, et cetera. At the end of the day, the way that it was written in the law, the agency could not implement. We absolutely could not implement because there was real-time claims analysis, and we couldn't implement it. And so at the end of the day, it was 3 or 4 years ago, we had to say, we're going to withdraw it. And so we couldn't do it. And so when you write legislation or you write regulations, you have to be really careful to make sure that it's actually implementable. And most legislation, I'm not saying this one, most legislation is not self-implementing. And so what's going to happen is then you're going to have to write a regulation on it. And so now that's time as well. And so it's trying to balance all those things, or can the agency do it quicker without legislation? I don't know.
You alluded to something right now and also earlier today, and I want to give you a chance to expand on it, and that is your opinion on the legislation itself, or your concerns about, and again, this is a hybrid. It's not fair of me to characterize it as MCIT. It's not MCIT. But it's again, hybrid MCIT-like,
right.
whatever however you want to characterize it. But talk about what your specific concerns are with the legislation and why you think that TSET, as it's currently, and again, it's a pilot program, but why you think that's preferable?
Well, it's actually a full-blown program now. They started in last year, or August of 2024.
Oh, right, the final guidance came out in August, right.
Okay, so, I mean, MCIT, there was a lot of problems with that. That was not implementable either. So the legislation, the last time I read it, and it sounds like there might have been some changes with it. My concern with it, at least the last time I read it, is that the burden was entirely on the government. And that really concerns me because that's never going to work. If the burden's only on one party, it's never going to work. And I think let me back up. There is a difference between FDA and CMS. There just is. And as you look at the whole ecosystem, you need to figure out who your customer is. Is it a payer? Is it over the counter? So the two of them must work together. So FDA decides what's safe and what's effective. So it does what it says it does. But what they don't do is how does it necessarily improve the health of a Medicare patient? What does it do there? And I have examples of that I won't bore you with. But there is a gap there. There is a gap. And usually especially with class 3 devices, when you go through the FDA, you are in a very rigid device. You're in a trial. You've got a lot of safety things around it. And so it's going to likely have perhaps a better success in that trial than if it's in the real world. And we really want to know how it's going to work in the real world. And so one of those bridges to figure that out is, as you heard Laura and Steve talk about today, and Perry as well, is coverage with evidence development and really gravitating to real world evidence and trying to do that, to bridge that gap. Because I think patients, clinicians, everybody wants to know that it works really well. And payers, I don't care if you're Medicare or private payer or VA or whomever, you want to know that it's bringing value to the patient. And so you need to do all of that. And so now going back to the legislation, my concern, and the last time I read it, and that legislation's hard for me to read because I commented on it so many times as a CMSer that it feels a little painful these days. But it feels like the entire burden's on the government, whereas it tells CMS, you will pay for this for 4 years. By the way, that was a random number we made up. But I'm glad you all took it on. So you'll pay for it for 4 years, and then you hopefully you'll develop the evidence that we all want. I really feel like there needs to be some burden also on the industry, where it's okay, you get 4 years of coverage, but here are the things you need to show. Like what are the valuable clinical endpoints that need to be demonstrated in the Medicare population? What are those? And if you don't meet them, what happens? There needs to be something that happens. If it doesn't work, if you're not going to do anything, and it doesn't work, but nobody does, so does the government still pay for it? I mean, that doesn't seem right, not only for patients, for taxpayers, for anything.
I mean, do you see the market having a role there?
Maybe. I mean, maybe that's
if it doesn't work, then it won't
I don't
be adopted.
know. I don't know. I mean, there's a lot of things that are out there that don't work, but we still pay, right? And so I feel like there needs to be some balance. Now, I just heard that there's something in the legislation for that, and I haven't seen it. But I just want some balance there. That sure, 4 years of coverage, but at the end of that 4 years, what happens? Is it non-coverage? What is it? Right. And if you do prove it, then it's national coverage.
By the way, if anybody has any questions, there's a microphone right here. It could be on anything. It doesn't have to be on something we talking about, anything reimbursement related. In the last few minutes, let me talk a little bit more about FDA and CMS. Unless I'm wrong, you were at CMS when the parallel review program was created. And we talked a little bit about Edwards' use of parallel review this morning when talking about the Evoke valve. What's your view? I know what your view is of the program, but I'm going to ask you to share that with everybody else. And what do you see as the problems with the program? And I mean, I think the general consensus is historically it has been underutilized and under-resourced. At least that's the perspective from industry. What's your view?
It doesn't work.
And why?
The idea is good. And we've learned and we've improved on it, but it's really, really challenging. So yes, I was there when it was developed, all those things, and it was a great idea. And today, the collaboration is a great idea. But the FDA, let's just give you an example. So CDRH, the device center, I think is in the thousands of employees, right? I think they're like 2,000, 3,000. The coverage and analysis group is 30 people. 10 of those people write national coverage determinations. So I don't think it's like, that's like one, what is that? I'm not a math person, 1 to 100? I mean, that's crazy. Like just the unevenness of that is crazy. But, and FDA does a great job. But not only that, the FDA has very rigid timelines. Like once you do, you all know this, once you put something in, it goes like this. And then when you negotiate your label, that label can change up to, a week, the day before? And so we're trying to react in real time and have time to review the evidence for the Medicare population and all of that, and trying to write a proposed decision on the day, or have the proposed decision ready on the day that they make that decision. There's no, I mean, even if we had all the staff in the world, that is really hard to do. The timing is just off. And so, and for a lot of different reasons. And so there's lots of ways for us to collaborate that doesn't result in parallel review. The concept of parallel review is very good. It's having those conversations early. It's when you're at the FDA, you know what CMS wants, and you make a decision of whether you're going to do it in that trial or you're going to wait. And so it's having knowledge to make the decisions and knowing what those decisions will affect moving down the chain of FDA approval, clearance, and then reimbursement. But parallel review, it's still there. I just don't think a proposed is possible on the day. It is possible, we've done it, but it's really challenging on the day of an FDA approval. I think TSET is good in the timing, because within like months of FDA approval, that is more doable.
knowing that, and well, let me say, putting aside the legislative viability of my next question, we know that resources has historically, or the lack of resources has historically been a problem at CMS, not due to anything people at CMS are doing, obviously, but due to political priorities through multiple administrations of both parties. You've said that you don't think a user fee program would work at CMS. And again, I'm putting aside whether this is a pipe dream, not talking about whether it could get passed. But,
right.
But what are your concerns about using that approach to increase CMS's resources?
So we looked at user fees. I mean, CMS needs so much more money, but to do what they do. But the user fee is really challenging because FDA, what they do is approve devices, drugs, et cetera. What CMS does, they do reimbursement, they have Medicaid, we have exchange, there's a lot of things. But because FDA, they have so many devices coming through the program that if you have a user fee, it doesn't appear that there's an influence from any particular manufacturer. Well, if you use it for NCDs, at one point when we had staff, we would do like 20 a year, but now we're down to 3, maybe 5 a year. That's really, really hard. Like, how do you do that? I don't think that we want to even have the perception that there's any undue influence. And I don't think anybody wants that. And so we have really been challenged to figure out how you would be able to get user fees into the agency, but spread them out on all these different things that we do. And then, so how do you do that? And that has been really, really challenging. I don't know I think the agency knows they need more funding, but that's been really hard to figure out to avoid any undue influence, perception, or otherwise.
In our last couple minutes, there's another pilot program that I'd like to get your take on that has caused some concern in industry circles, and that is the WISER program. You thought you could get away with that talking about it?
I know.
Yeah. From a pre-authorization perspective. And this also kind of came up on the last panel, but what do you see as the pros and cons? Certainly, I mean, you want to go into the skin substitute, that whole issue. But again, is that a case of kind of throwing the baby out with the bathwater? I mean, it's like when people talk about, well, the new medical device regulation, MDR in Europe, arose out of the PIP breast implant scandal, which was basically fraud.
Right.
I don't know how you expect to legislate against that. But talk about it with the WISER program generally.
I mean, I think the intent is good, which is trying to make sure that CMS pays for the things that are appropriately should be paid. And so, I made recommendations when I was the coverage director on what should be the NCDs and the LCDs that should be in the WISER program that they should test out. And I do think the staff that's writing that and that is pulling that together has very good intentions, and it's iterative. I think they'll change things as they learn. So that I think is really positive. And I think it was put together really, really fast. And so that's going to be challenging, but I just keep commenting, and I think they'll do some iterative changes to all of that. At least that was my impression. But it really is to make sure that they pay for the things that they should be paid for, because there is a lot of things CMS is paying for that we shouldn't, whether they're just not catching it. I mean, the claim system is a yes system. Hopefully that's not a secret. It's a yes system. And so this is a way to catch it before you pay for it so they don't come after and claw it back. And I know we're running out of time, and we could go through that. Skin subs that's just an anomaly. I mean, that was years and years in the making, and it's been a really tough year in skin subs area. But that's a whole conversation, whether we're talking about LCDs, the physician fee schedule, and how we got to where we are today, of over $5.2 billion in fraud.
Well, great. Well, any questions for Tamara? Really appreciate your time, but more than that, just appreciate your openness.
We hope you enjoyed that conversation with Tamara Syrek Jensen, Rarely do you get even a former government official to speak that openly and honestly about the challenges facing their former agency, as well as the challenges facing the system itself, while also offering helpful suggestions for companies to better work with regulators going forward. To read the full copy of the interview, please refer to the January issue of Market Pathways. Thanks again for listening, and we hope you can join us for a future edition of the Market Pathways podcast.
We hope you enjoyed that episode. Your support is valuable and makes us better. Please remember to leave a review and rate Market Pathways on Apple Podcasts or wherever you happen to listen.